Ibrahim, unmute.
All right, are we ready to begin? Good evening, everyone, and welcome to the Wits Students Surgical Society's third lecture series for the year, Saving Smiles, Cleft and Right. My name is Ibrahim Mullah, and I'm a second-year medical student at Wits. I would like to begin by firstly thanking every one of you for attending this event. Although the pandemic has restricted us to an online platform, it is through you, our loyal viewers, that we are able to successfully host these events time and time again. Before we begin with the lecture series, joining us today is Ms. Kim Robertson-Smith from the Smile Foundation, who will be presenting a brief introduction as to who the Smile Foundation is, as well as their purpose. Mrs. Kim is the general manager of the Smile Foundation. She was in theater for the very first Smile operation that took place in Charlotte Maxeke, Johannesburg Academic Hospital, and she has been involved in the medical fraternity for more than 21 years. Kim has joined the Smile team to help Smile grow into its majority. Mrs. Robertson, the floor is yours. Well, the virtual one at least.
Thank you very much, Ibrahim. So, first of all, I just wanted to say thank you for all that you guys do for the Smile Foundation and all I believe you're going to do in the future. So we're really looking forward to seeing you growing and assisting and nurturing you. And also thank you very much to Dr. Tjasink for doing the lecture for us this evening. So I'd like to share my screen now so we can get on with that. Okay, can you guys see this?
Yeah, we can.
Okay, cool. All right, so you see me as well. All right, so Smile started in the year 2000 when Nelson Mandela was contacted by a mom desperate for help. Her daughter had Mobius syndrome and she was unable to smile at all. So she contacted Nelson Mandela in those years, and he then contacted Mark Lubner and Professor George Saris. And both of them took up the challenge and the Smile Foundation was born. So, sorry, my screen's not actually changing. Sorry, guys, my screen's not changing. I need to change that screen.
Or try your arrows up and down.
There you go, got it. Okay, so that was the beginning of the Smile Foundation. Okay, so who are the alliances behind our organization? So it's the academic hospitals, the private stakeholders and donors, the local Department of Health, the partner NGOs, educational support and organization, the allied therapeutic, dental and medical services, and of course the National Department of Health. So without all these alliances, the Smile Foundation wouldn't exist. So at a glance, what Smile Foundation actually does is we're involved with the patients, with the hospitals, with the personnel, the doctors, the nurses, the allied professionals. And our main focus is awareness and education, and then support of the patients during, during and post-op surgery. So we offer psychological support, transport, meals, speech therapy, all of that to the patient. And then of course, through the hospital, we offer extra nursing staff, surgical equipment where it's needed. In the consultants, we support them in international fellowships, congresses, the medical students for local congresses, Smile Weeks, all of that. And then of course, the auxiliary services who are so essential to us. And then our awareness and education is the campaigns using social media to offer surgery and support, and all of our outreach programs. So we're working in approximately 11 hospitals, at least one per province. And we're involved with so many hospitals to assist as many children as possible throughout the country. So the 4 phases of the Smile Foundation is the medical and surgical treatment of the children with facial disabilities, the specialized multidisciplinary support, the mother-to-mother support, and under that we have a group called U-Matter that was established in 2019, and U-Matter is to do with burns. So we support the mother-to-mother support with U-Matter. And then in 2013, we established Cleft Friends, which is also under our auspices, and that is to support parents who have cleft children. So that support is done via WhatsApps, SMSs, direct contact, all of that, just to make sure that the parents are also looked after. And then, of course, the patient-to-patient support that we also offer. So how does Smile Foundation support the academic hospital? So basically with time, with money, of course, and creating, offering assistance, creating awareness, and with social media. So what is a Smile Day or a Smile Week? So essentially up until now, we've had Smile Weeks, and then that is a week of surgeries where we try and put the backlog to bed, basically, of kids who haven't been able to have reconstructive surgery, and we would then have a donor who would sponsor an entire Smile Week. Now, with COVID, we've had to change that up a little bit. So what we're trying to do is then offer a Smile Day, which will run 1 day a week for a month or 2 months, or however many funds we manage to collect to actually look after these children. And then included in that is the psychological support for patients and caregivers, including parent workshops, any transportation or accommodation from those kids that live outside the very close area to a major hospital. We do speech, nutrition, and occupational therapy workshops, academic skill programs for the registrars and the healthcare professionals, the medical equipment that some hospitals need that they actually don't have available to them. We do fundraising for that. And then additional nursing staff where requested. So it's for us to be able to do surgeries on as many kids as possible, because there's nothing so beautiful as the smile of a child. And all of you who have children do know that. And the thing is, a smile, a child who can't smile, it's not just the child who suffers with that. It's the parents as well. And the other kids who are so cruel to kids who can't smile. So what we want to do is make sure that those kids can smile again. So the benefit for the patients and the parents is that we give them information, trauma counseling and support, transportation, and then all the psychological counseling, and then speech and OT. So that comes in with the allied professionals. The patient support process is a circle. So we made aware of a potential patient via email or phone, and those parents are then referred and they're given a date for clinic or a visit where they can be assessed by a plastic surgeon, and then they can go forward for a surgery date. Should the patient present with a cleft lip or palate, they're given additional support from Cleft Friends. And then on the day of the surgery, both parents and patients have a session with a psychologist. And depending on the needs of the patient, the date will be then rescheduled for speech or occupational therapy. And then the patient's tracked up with the following sessions as they need dental surgery or therapy sessions. So we're currently working with the Department of Dental Surgery to see if we can have a better collaboration with them, because we have had a few hiccups with them, but it looks like the process is going to work a lot more smoothly. So our main focus really is the well-being of the child and the care and support of the child pre-operative, during the surgery, and post-operative. So yeah, Please, guys, if you want to continue helping us or you want to spread the word about the Smile Foundation, we will be incredibly grateful. So every cent that we receive goes to putting a smile on a child's face. And we are looking at bringing joy. And that's me. Thank you very much. Thank you for listening.
Thank you so much for that, Mrs. Robertson. The Smile Foundation is truly one of paramount importance. The work done by the foundation has truly improved the lives of so many. And on behalf of our surgical society, I would like to extend our gratitude to both you and the Smile Foundation for all the help provided to us, either through sponsorships as well as helping us organize events such as these. We truly appreciate it.
It's a great pleasure.
Thank you. I would now like to welcome Dr. Gareth Tjasink, who will be presenting the main event for the evening, Saving Smiles, Cleft and Right. Dr. Tjasink received his medical degree at UCT, but soon realized his mistake and came to Wits to do his FC Plastics. In addition to being the deputy head of burns at the Chris Hani Baragwanath Hospital, Dr. Tjasink also runs private clinic practices in Linksfield, Malbaton, and Alchemia. Many of you might even recognize Dr. Tjasink from Survivor, where he achieved 5th position. Dr. Tjasink, we thank you for taking time out of your busy schedule to be here today. Please go ahead.
Kim has to stop sharing so that I can share. Kim, can you stop sharing so I can share? Okay, all right. So I'd like to correct you. I got to the 3rd position and then they brought people back. So I felt like I was robbed. Okay, there we go. So, firstly, I'd like to thank Smile because Smile makes a massive difference. You guys might not know yet because you haven't been there, but from getting ET tubes that fit children to sutures when you need sutures because our amazing health department had issues, then they step in and step up whenever we need it. It's not just about making Smile; they literally save lives on a daily basis. So they reach far further than just a cleft lip or palate. So yeah, thanks very much to them. They do make a huge difference and money is well spent there. So I work at Linksfield Hospital as my main private practice and then Baragwanath Burns. So this is a little girl that's had a cleft lip repair. So because of your smile, you make life more beautiful, and that's more true than ever for these little kiddies. Smile reaches across many levels and many platforms, but basically for the Smile Foundation, what it initially started as was for treating cleft lips, cleft palates, and facial paralysis. And then they started stepping into helping out with burns, which is where I deal with a lot of them. They buy very expensive products that are not available in state. They allow us to do some sort of experimental procedures. When I say experimental, I mean the products are available in first world countries, but not available here yet. So they step in, and if we motivate, they'll buy something for a kid. And I'll show you a case I did where they stepped up to help out a little bit later. So cleft lip and palates. This is a bilateral cleft lip and cleft palate. As you can see, for a kid growing up like this, there are major issues that this child is going to have. This child can't smile properly. This child can't eat properly. This child can't speak properly. So there are multi-level supports needed for this child of this nature. Cleft lip, just some academics for you guys so that when we go through, you understand. You probably won't have to deal with the level of information that we've got, but it's a brief overview. A cleft lip is a congenital abnormality of the primary palate. The primary palate is what lies anterior to the incisor foramen, which is a little hole in the hard palate. And it consists mainly of your lip, your alveolus, which is your teeth, and your hard palate anterior to this little hole. So that's your cleft lip. Your cleft palate is a congenital abnormality of the secondary palate. And your secondary palate lies posterior to this little incisor foramen, and it consists of your hard palate, which is your maxillary floor, and your soft palate, which is further back, and it consists of the muscles in the uvula. So cleft lips with or without cleft palate is the most common facial defect in the world. most common facial birth defect in the world. It ranges from about 0.2 to 2.3% per 1,000 births. So even though it's quite the most common defect, it's not very common. And the overall incidence of oral clefts is 1 in 750 live births. So 46% of those will be both cleft lip and palate, and 33% will be cleft palate only, and 21% will be cleft lip only. So this is a diagrammatic representation, just to give you an indication of how complex the cleft lip and palate procedure is. You know, when you're doing a cleft lip repair, you're not just attaching skin to skin. You have to reconstruct the muscles of the orbicularis oris because they insert incorrectly into the base of the nose. So your defect is not going to only include the lip and the perioral area. It also includes the nasal area, the nasal floor. So there's a significant asymmetry of the nose, and all the tissue and all the muscles insert into the base of the nose. So the whole muscular structure is deranged. So when you do the cleft lip repair, and these pictures are kindly sponsored or lifted from Nelligan's, which is our textbook. We end up having to do multiple points where we measure, we do careful measurements of how are we going to lengthen the upper lip because there's a deficit in length of the upper lip. We measure where the muscles need to go, and we try and correct the nose at the same time. This is an indication of how you would try and create the height of the vermilion, which is the pink part of the lip, how we would try and line the scar in your Cupid's bow, which is the two little lines just under your nose, and then how we will try and sit the muscles in the correct position. This is a little kitty that Smile Foundation sponsored. These pictures are thanks to Smile, and this is a picture of her afterwards. So this is a surgery that is quite difficult, and the lip will never look 100% like a normal lip, but it is quite far less debilitating from this situation. Now, as you go into your academic careers and you're going to be working as interns, you're going to be faced with kids that have these defects, and you're going to be faced with kids with cleft palates. And I'm going to chat to you very briefly about how you're going to deal with them as the sort of initial consulting doctor. This is another little girl that had a cleft lip repair. You can see the nose is quite asymmetrical, and then surgery is done to try and symmetrize the nose as best as possible. So a bilateral cleft, as you saw in the first picture, is a very complex repair. Your promaxilla, which is this little piece that sits anterior to everything else in the nose, I'll go back to show you. Because it's not being reined in by the tissues on the lateral aspects of the promaxilla, this piece everts and is quite prominent in the facial alignment. So it needs to be seen by maxillofacial surgeons for taping, or alternatively by occupational therapists, where a mold is made to try and rein this premaxilla back in. A bilateral cleft lip surgery is quite complicated. As you can see here, there are multiple little dots that are measured. Each of these little dots has specific measurements that are accounted for with calipers. It's quite a mathematical process, and it should be done by a super specialist. And some of the best surgeons in the country are available in Joburg, like Prof. Chait and Prof. Christofides, who are very good cleft surgeons. And if I have a patient that I would be concerned about, I would refer to them. If you have a look at these diagrams, you can see we remove some of the tissues. We try and recreate the vermilion, the internal sulcus of the upper lip. We try and recreate the sill of the floor. We put the mucosa back into its correct position. And we then reconstruct the muscles so that they're in a continuous area. The sill of the nasal floor is reconstructed. We try and get the vermilion correct, and then the skin. So it is a complex surgery in very small patients with a lot of very fine tissues. This is a little kitty with a bilateral cleft lip, and that's him after his surgery. Your cleft palate is a different entity. Although it can occur in unison with a cleft lip, a cleft palate on its own is a completely different genetic entity. And there are different theories on how these evolve, and I don't think that scope is in this talk. But if you have a look at the image on your left, you will see that your palatal sling and how the soft palate functions for creating sound and making swallowing better and not allowing nasal regurgitation, etc. You can see that there's a significant defect in a cleft palate. The muscles all insert incorrectly, and there's no unison and there's no seal when you swallow. So nasal regurgitation is a very big problem, as well as phonation. Any sound that the child tries to make, there's nasal escape. So the child cannot make the KP sound. So it's very difficult for the child to create a conversational speech. These are some examples of different techniques for the repair. As you can imagine, it would be quite difficult to get into the nose to put those sutures, so it takes quite a skilled surgeon to get there. You have to recreate the mucosa in the nasal floor. You have to recreate the palate. You do what's called a furlough double Z plasty, where you realign the muscles as best you can and try and lengthen the palate, because there's a deficit in the length of the palate. And all of this is done, and then once that is healed, the child still has to learn how to use that palate. So it is a long road for a little kiddie. Now, the Mebius syndrome that Kim mentioned earlier is probably the most common, probably the biggest surgery that we would do for Smile Foundation. When I say biggest, the most complex. These kids are born with zero facial nerve movement. So they have what's called a mask facies, and they have no expression whatsoever. And so it is what most commonly kids would present with when they have a facial paralysis. But there are other causes. So it's things like a stroke, Bell's palsy, a traumatic injury, or a tumor can all cause facial paralysis. But in Smile Foundation, the kids is generally a Mebius syndrome. So these effects can include difficulty or inability to smile, difficulty or inability to close your eyes, decreased production of tears, corneal exposure and damage because of the inability to close the eye, facial asymmetry or lack of any expression, drooping of one side of the face of the mouth or depression of the brows, and then nasal airway problems. When you have an acquired tumor cause, it could be an acoustic neuroma. These are benign growths that occur on the nerve adjacent to the facial nerve, and it controls the facial nerve, which controls facial motion, which you should know if you've done any anatomy. And that compression then inhibits the function of that nerve, so the patient becomes asymmetrically paralyzed. A Bell's palsy is the most common cause of facial paralysis, and it's caused by damage or inflammation of the facial nerve. And we know that controls motor function of the face and will result in a paralysis. Other causes are Lyme disease or stroke or trauma and cutting of the nerve, etc. But your congenital causes are what we would see in kids, and this is what mainly the Smile Foundation deals with, like Mebius, hemifacial microsomia, Di-George syndrome, Albers-Schonenberg, and Charge. So how do we get a kid to smile again? So muscle transfer is your primary method of facial reanimation in these kiddies that have issues with congenital abnormalities. You bring dynamic mobility to the paralyzed regions of the face by moving muscles from other areas of the face, or more likely in a congenital cause from a free flap, where we bring muscle from elsewhere in the body. So the transfer of these muscles provides motor to recreate the movements of the face, and particularly in the mouth area. And you either use facial muscles that are working already, like a temporalis muscle, which you flap down, or you bring in other muscles, because if you have a Mebius syndrome, there's no facial muscle that works properly. So this is actually quite blurry, but this is an indication of how we would take a sliver of the temporalis muscle and bring it down under the zygomatic arch and attach it to the corner of the mouth, changing its arc of motion. So when the patient would bite down or clench their teeth, they would get an elevation of the corner of the mouth. It's not a natural smile, but it gives an indication of emotion. This is the main procedure that is done when we do facial reanimation in Amoebius syndrome. So if we have a look here, we remove a small segment of the gracilis muscle. This muscle is harvested with its adductor artery and vein and the anterior obturator nerve. This muscle is then placed in position in the face, and the facial nerve and facial artery are joined to the branches of the adductor artery and the adductor vein, creating a well-vascularized free flap. The anterior obturator nerve is then placed in position with the masseter nerve. So what happens is when the child would clench down on their teeth, they would create an impulse to that nerve, which would cause shortening of the gracilis muscle and elevate the corner of the mouth. So in surgery, we would do one side first, let the child heal, and then they would undergo another treatment for the other side to create another gracilis muscle graft and gracilis muscle flap. The thing is that these smiles are created by the clenching of teeth, and the child has to learn that when they're happy and they're expressing that they need to clench their teeth to smile. And with time, this can become quite a natural looking, well, not as natural as a natural smile would be, but a smile that portrays emotion and is quite sort of relieving for the family as these kids can now express, because previously with Moebius syndrome, there's no facial expression whatsoever. So you do not know if your child is happy, you do not know if your child is sad, and it's quite distressing. Nerve grafting is another option. Nerves can be taken from your sural nerve, which is one of the main graft or donor nerves in the body, because it's a sort of a large caliber nerve that supplies sensation to the lateral aspect of the foot. And if we take it, a little bit of numbness on the side of the foot's not a drama. That nerve is then used to bridge the gap from one side of the face to another side. So we would take, if there was trauma, we would take a sural nerve and bridge it from one facial nerve on the one side to the facial nerve on the other. So when they fire, it creates a bilateral impulse, and then you'd have expression on both sides of the face. This is an example of what I was talking about when you do a sural nerve graft across to the other side of the face for expression. This is a very natural expression because it occurs spontaneously, so it's a spontaneous smile. Nerves grow exceptionally slowly. They grow about 1 millimeter per day, so it can take a good couple of months for the nerve to go across. And if we are dealing with a trauma, we have a limited time frame before motor end plates die. In other words, the muscles do not respond to nervous stimulation anymore. So we have to do these sorts of surgeries relatively quickly. This is my patient that Smile stepped in and helped. And she was a young girl who was, when I met her, she was 6 years old. She had been attacked by a dog. The dog had scalped her, and she had lost majority of her overlying hair on the scalp. What you see in front of you is a split skin graft that was placed over the cranium, and with time, and she had and sort of healed up. But obviously for a young girl, this is a devastating injury. On the left-hand side of the picture, you can see a swelling, and we'll go through what that is in a second. So that's what the swelling is, and this is what Smile bought for us. It's a soft silicone bag that has a little port with a metal connector. The little port is buried underneath the skin further down the scalp, a little bit behind the maxillary process, where it is covered by a thin layer of skin, and we would use a needle with fluid to inject into the injection port, and we would slowly blow up the soft silicone bag with saline over a period of a couple of weeks. With that, we'd eventually get a recruitment of the overlying tissue, which would expand and expand until we have enough tissue to recreate the deficit that we're trying to get removed. So if you have a look at her, you can see, and you can imagine a little girl like this going to school where cruel kids give her a hard time because she's got a balloon growing out the side of her head. So she is an exceptionally brave little girl who went through the whole procedure, followed up every appointment, always with a smile on her face. We blew up her scalp and recruited as much hair follicles as we could. And then when we closed her up, she ended up having a scalp that was covering most of her head. She has got a large scar, which we will be revising again, but she has full head of hair. And now if she wants to wear weave or dreadlocks or anything that she feels that she would like to wear, she has something to attach it to and will live a pretty normal life, as opposed to having a balded head. So this is, again, Smile pays for these this equipment that's not provided by state. They pay for the follow-ups. They assist the children coming to and from these multiple clinic visits. They provide social support for the mother, education. It's an invaluable NGO, and one of the few NGOs where the money actually goes where it should go. So that's an overview of the whole process. It's a little bit short, but I mean, the information that we have is very in-depth with regards to the different pathologies. But I just wanted to give you an idea of what can be done and what we do in government in this country, which is quite phenomenal. Alrighty, thanks very much.
Thank you so much, Dr. Tjasink, for enlightening us all. That was very, very, very interesting. Your lecture has definitely put a smile on all of our faces. To all our future doctors, health science students, and other medical enthusiasts, lecture series like these are really important to help spark some interest in new fields. We appreciate learning and hearing about your dedication to helping these children find their smiles. Thank you for teaching us about the differences between cleft lip and cleft palate and how you can approach these two. Learning about smile reanimation was very interesting. The fact that you can take a thigh muscle and build someone's smile is absolutely amazing. So again, thank you so, so much. And we look forward to seeing you again. And on behalf
of... Thanks, it was a great pleasure.
On behalf of all the survivor watchers, in my possibly biased opinion, you deserve to win.
Thanks very much.
Now we're going to be hearing from Anri. Anri Smit is a fourth-year medical student, and she is the head of outreach at the Wits Students Surgical Society. She'll be telling us a little bit more about the SMILE campaign and what it's all about. So thanks, Anri. You can take it from here.
Thanks, Nadia. Okay, I'm just going to get my screen up. Okay. Good evening, ladies and gentlemen. It is my pleasure this evening to briefly discuss some exciting initiatives we are hosting for the SMILE Foundation this September in collaboration with the students of the TICS and Stellenbosch Surgical Societies. Since the beginning of lockdown, there has been a medical backlog in the public health system. Our efforts to unite as student surgical societies across the country for this cause has arisen in response to the desperate need to reduce this backlog of children waiting to receive their facial surgeries since the beginning. So let me take you through some initiatives we are hosting. The first initiative we are hosting is the Best Smile competition. in which we are inviting students across the universities to give us their best and most creative smile to bring awareness to the Smile Foundation and the children they serve. We welcome entries from anyone, and all you need to do is post a photo of your most creative smile, try and use some props if you can, and tag all three societies, and importantly, tag the Smile Foundation for a valid entry. The competition closes the 24th of September, and we will announce the winner on the 26th. The lucky winner will receive a Smile scrub cap and a Smile branded hamper. So please, please enter. Now for our second initiative. This is our virtual Kilimanjaro climb. The iconic Mount Kilimanjaro has seen climbers from all walks of life, including several generations of Surge Stock Committee members, as you can see on the photo on the left, reach its summit in an effort to raise funds for the Smile Foundation. This year, due to the pandemic and the uncertainties surrounding traveling, we have decided to bring you a virtual summit, which you can do in your very own neighborhood. And since we know that walking 100 odd kilometers is a bit of a tall order for most, we have decided to take this event to a slightly different height. So for this virtual event, we invite you to walk or run the distance that's equivalent to the vertical height of Mount Kilimanjaro, which is roughly 6 kilometers. You have the option to choose between 6 kilometers, 12 or 18 as your desired distance. And you can take part in the event anywhere and anytime on the 26th or the 26th of September. And each individual can do it at their own pace. You will receive access to a timing platform, a virtual race bib with a race number, which you can download, as well as a custom completion certificate, which you can also download. And friends, family, colleagues, neighbors, anyone is welcome. The more join, the more smiles we can give. So please book early to secure your ticket. You can get your tickets at web tickets, as well as pick and pay stores nationwide. As I said before, those are the distances. Each ticket is 50 Rand and all proceeds go directly to the Smile Foundation. And you can also go to webticket.co.za, as well as you can also visit the Smile Foundation's website and their Facebook page for more information. All of the links are provided at the bottom of the slide, and I'm happy to forward it to anyone who requests it afterwards. If you don't feel up for the challenge to run or walk the 6K or so forth, you can just help us to raise enough money to cover a full day theatre slate. So donations can be made at this link available on the slide. And it's also available on Smile Foundation's website under fundraiser, under the fundraiser tab, as well as on each of the surgical societies involved on the Instagram bio. So thank you. And for any questions, I'll be happy to answer at any time. I'll also be happy to share my details with anyone should the need arise. Thank you very much.
Thank you, Henri. I'm sure everyone's looking forward to getting really creative and getting some exercise this Smile Month. Yeah. So now it is time to do our lucky draw and see who the winner will be for a lovely pair of Smile scrubs. I've got a random name generator, and let's see who the lucky winner is. Malefa Mukone, would you please send a message or comment on the YouTube live stream so that we can contact you? Congratulations on your Smile scrubs. I think now we're going to be taking some questions. Abraham, would you like to start?
Sure. Dr. Tjasink, this is the first question, and I'm also particularly very interested in this one. What made you consider this line of work or specialty?
So plastic surgery is an unusual field for medicine. And as I'm sure most of you can attest, science is very rigorous in the medical field, and there's very little creative outlet. So plastic surgery is kind of one of the few fields in medicine where you have a combination of the two, where there's an aesthetic appreciation of things, and then there's a satisfaction in making something pretty again. Also, there is a very few fields in medicine where people are excited to see you. If you're going to the cardiologist because you're having a heart attack, you're not super happy to see them. When you're going to a plastic surgeon because you want to look better or feel better about yourself, you're quite excited about it. So there is an energy in a consultation that does translate into a feeling you take home with you as a surgeon. The other one that's very much like that is gynecology and obstetrics. You're very excited to go and deliver a child. So there is an element of a transference of that energy, and you feel like you've achieved something exciting for the day. Saving a life there's nothing better than saving a life, but losing a life is also quite taxing. So when you have plastic surgery, your patients are generally not on death's door, except in the burns unit where I currently work. But you tend to have quite a steady, comfortable, safe surgical field, which is well controlled, well thought out, planned well in advance. And that's also quite a satisfying surgical field to be in. So, I mean, when you're preparing to do a facial reanimation, the child is safe, the child is well. Your risks, if you do everything correctly, are going to have a good outcome. You shouldn't have issues with children having adverse events if you plan correctly. These things do still happen because it is medicine, but that is kind of where we go. So for me, that's a long question, a long answer for a short question. It's the all-encompassing medical field for me.
It is truly enlightening. Thank you so much for that. And following up on that question, what path would an MBBCH graduate have to follow to be in your position?
So it is a long path. Okay, so I did 6 years of medicine. When I did internship, it was 1 year. And I'm not that old, but it was a 1 year internship and 1 year comp service. And now it's 2 years for you. Then 2 years of medical officer time, through 38 months of general surgery reg time, and then 4.5 years of plastic surgery reg time. So it's a long road. If you know what you want to do, and that's what you want to do, you get out of med school quickly. You, in your comp serve year, do some research, and then go and be a medical officer in the plastic surgery department, and then you can streamline it that way. You will work very hard. You think plastic surgery is not busy, but you're on call for a week at a time, and you get called every day for everything. So it's a lot of hard work, but it's very character building.
And how long after you got yours, after you specialized, did it take for you to become the deputy head of burns?
So I ran a burns unit at Leratong for 1.5 years, and then the opening came up at Baragwanath, and I applied for that and got it. So it was about 2 years after I qualified. But I had been in the burns unit for a very long time. I did, during my comp serve, I did 6 months of pediatric surgery where I ran the peds burns unit with ped surgeons. And then I did 1.5 years in Leratong, and then so basically my burns experience was about 3 years by the time I applied for the deputy post.
Thank you so much for that. Nadia, would you like to continue?
Doctor, we have a question here. When did you realize that you wanted to be in the field that you're in now?
So funnily enough, wanted to do psychiatry when I started, and then I did psychiatry and I didn't like it. So then it was a surgical field for sure. And the surgical fields that were opened up, I had an interest in maxillofacial, which was reorganizing facial bones. And then I had an interest in ear, nose, and throat, but then I realized I didn't like that much saliva. So plastic surgery was the field that sort of drew my attention quite early in my internship. So I did an elective and I really enjoyed the procedure. My first procedure I watched was a female to male procedure where they created a penis out of a forearm. It was a functional penis. When I say functional, it had sensation because they connected it to the pudendal nerve with the radial nerve and with the radial cutaneous nerve. So it was quite an interesting thing to see. And that for me was sort of like, wow, that blew my mind that there was so much that we could do with surgery. One of the most interesting surgeries I've been involved in is with Dr. Liakos, who's a very good free flap surgeon, where we would take the fibula bone with its blood supply and recreate a jaw after cancer has eaten away the jaw. So the stuff that can be done is quite phenomenal.
Wow, that's really, really amazing. Crazy. And what are the most common complications that you find in the surgeries that you do?
So if you're doing cosmetic surgeries, the most common complication is an unhappy lady or man who has an idea of a filtered Instagram image that she's going to get, which is not the reality in life. But if you're talking about the complications relating to specific procedures, they're very varied according to the procedure that you're doing. But most commonly, your risk is that your blood supply to the tissue that you are carrying as a plastic surgeon is at risk. So you get a little bit of necrosis of the edges of a flap, or you get a little infection, or you get a hematoma that develops that you need to evacuate. But majority of the time, they're manageable and the outcomes are not really risked.
And after you do a surgery, is there often where you have to do a follow-up surgery, or is it usually just the one surgery that you do and then it's done?
So plastic surgery in itself is fine-tuning of a problem. So the outcomes are better if you can do little bits of refinement continuously. So having 10 surgeries for a procedure, so for a cleft lip or nose, is not uncommon in America or places where surgery access is much more amenable. But generally, one-stop surgeries will never have the outcome that you would expect. Well, when I say expect, we would never have the outcome that you would hope for. So a combination of multiple little refinements is not unheard of and actually gets you a pretty good outcome.
Thank you so much, Doctor. I think one of the last questions, I don't know if we have any more, but if someone is interested in this field, is there anything that you can suggest them to get more exposure and try and build on their interest in plastic surgery?
Sure. The department has got quite a large number of plastic surgeons who work in private and in government as well. So electives in different branches are quite common. I have lots of students that come through to the burns unit to spend some time in the unit just to see what's going on and see their field. But my best advice would be to send a letter or an email to one of the private surgeons in the area and say, I am a student and I am looking at potentially doing some surgery, a plastic surgery elective time. Would it be okay if I spent a day with you? The big issue with this is that a lot of the patients that come through for these procedures are not interested in having people know who they are. Can you see me still? It says my connection is unstable.
Yes, we can see you.
So the privacy relating to the different procedures is the issue. So, you give them a call, say if anyone doesn't mind, could I come and watch 1 or 2 surgeries? We do a lot of hand surgery and plastic surgery. So we do like hand reconstruction and tendon grafts and nerve reconstruction and that sort of stuff. And those sorts of patients are a lot more amenable to being watched rather than someone who's coming in for a tummy tuck and a mommy makeover, because she might know you.
Oh, okay. Sorry, just a few more questions from the group. Someone is asking, what are the implications with cleft lip and palate in terms of their hearing?
So what happens with the cleft lip and palate is because of the, can you hear me?
Yes, yeah, we can.
Okay. So what happens with the cleft lip and palate is because your eustachian tube, it connects with the posterior throat, you end up having aspiration of the food, etc., and the particles. So ear infections are very, very common in these patients, and they need to have auditory assessments quite early on to see that there's not a significant amount of damage, and they need to see a speech therapist and an audiologist, and we try and prevent those infections and do the repair relatively soon. When you're also a child, you must remember that your ear canal, your eustachian tube is very horizontal versus vertical, and that's why the ear infections are so significant.
That's absolutely fascinating. Thank you so much for answering our questions. We really, really appreciate it. Now I think we're going to hand over to Anri, who will do the final thank yous.
Okay, so on behalf of the Wits Students Surgical Society, I'd just like to thank our wonderful speakers, Kim Robertson and Dr. Tjasink, for your time and your input and for enlightening us this evening. We really, really appreciate having you as our guests of honor. And we thank you for all the work you do for children with facial anomalies in South Africa. Yeah, it was absolutely fascinating to learn in more detail about the work and the level of involvement of the Smile Foundation in each and every single case, as well as the intricacies involved with every procedure needed to correct such facial anomalies. So thank you very much. And I'd also like to thank each and every attendee for taking the time to join us this evening. We hope that it inspired you and that you thoroughly enjoyed it. And then I would just like to conclude by encouraging each and every one of you who are listening to please enter our Best Smile competition. It really is so quick and easy to enter, and you can win an awesome prize. And I'd also like to challenge you to take part in the virtual Kilimanjaro event and invite your world, invite your friends, your family members, your peers, colleagues to join in as well. Because by doing these small acts of kindness, you will not only be helping us to bring awareness to the Smile Foundation, but every penny goes directly to the Smile Foundation and helps them to continue the good work that they do. Finally, please share our posts to encourage others to take part. And because we'd really appreciate all the help we can get in this inter-society campaign for the Smile Foundation. And that's all from me. I hope you have a wonderful evening further and take care.